Hello and welcome to our podcast, JAK Inhibitors in the Treatment of SLE, Targeting a New Pathway. My name is Ed Vitale. I'm chair of the Lupus Forum and I'm Professor of Translational Medicine at the University of Leeds. And I'm delighted to be joined today by three of our expert faculty, Professor Cynthia Aranow, who's a Professor of Medicine and Molecular Medicine at the Feinstein Institute for Medical Research, Professor Richard Furie, who's a Professor of Medicine and the Chief of Division of Rheumatology at Northwell Health, and Professor Chris Edwards, who's a consultant rheumatologist and honorary chair of clinical rheumatology at the University of Southampton. So these are our objectives for this podcast. We're going to be discussing the role of the JAK-STAT pathway in the pathogenesis of SLE, looking at the emerging evidence for the use of JAK inhibitors for SLE, and then aiming to understand the long-term efficacy and safety data that's needed for JAK inhibitors in SLE. So first of all, we'll have a look at the pathogenesis of the JAK-STAT pathway from Professor Aranow, and then we'll have a presentation about data from the clinical trials from Professor Furie, and we'll finish up with a look at the future potential of JAK inhibitors in the treatment of SLE. So without further ado, I'm going to hand over to our first speaker, Dr. Aranow.
So thanks, Ed, for your introduction. So my charge is to provide an overview of the JAK-STAT pathway, and particularly the JAK-STAT pathway in SLE. These are my disclosures. Okay, so the JAK-STAT pathway is a pathway that's evolutionarily conserved and is a key mechanism for the communication of extracellular signals to the nucleus. So this signaling cascade plays a crucial role for maintaining immune tolerance, resisting infection, immune surveillance, as well as enforcing barrier functions. More than 50 cytokines, growth factors, and hormones bind to cell surface receptors and then transmit their effects via the JAK-STAT pathway. The players of the JAK-STAT pathway include 4 JAKs, JAK1, JAK2, JAK3, and TYK2, and 7 STATs. These JAKs are non-covalently linked to receptors on the cell surface. JAK1, JAK2, and JAK3 are expressed on all tissues, while hematopoietic cells and endothelial cells primarily express JAK3. The 7 STATs are present in the cytosol. Each JAK consists of 4 domains. The kinase domain, which is the active functional site, which mediates tyrosine phosphorylation. A pseudokinase domain, which regulates the kinase domain, as well as a SH2 domain and a 4th domain labeled FIRM, which basically regulates the JAK and cytokine receptor binding and associations. So the signaling cascade is initiated by the cytokine binding to the cytokine receptor on the cell surface. This leads to phosphorylation and activation of the receptor and recruitment of the JAKs to the receptor and then JAK phosphorylation. The JAKs phosphorylate each other as well as tyrosine residues on the receptor, forming a docking site for the STATs. So STATs are then recruited to the receptor and bind to the receptor docking site. The STATs are then phosphorylated by the JAKs. Next, the phosphorylated STATs dimerize or heterodimerize, disengage from the receptor, and go into the cytoplasm. Finally, the STAT complex translocates to the nucleus, where it binds cytokine response elements, resulting in gene expression. So understandably, this signaling cascade is highly regulated, and it's inactivated by a number of proteins, and these include the SOX, suppression of cytokine signaling, protein tyrosine phosphatases, which remove phosphate groups from the tyrosine sites, as well as protein inhibitors of activated STAT or PS. So the specificity of the JAK-STAT pathway originates with the cytokine receptor and the particular JAKs and subsequently STATs that are recruited to that receptor. So as an example, binding of IL-6 to its receptor, I don't know if you can see my pointer, results in recruitment and activation of JAK1, JAK2, and TYK2 to the receptor, then recruitment of STAT3, which translocates to the nucleus, binding to the DNA, and resulting in transcription of genes associated with the effects of IL-6. So the role of alpha interferon in the pathogenesis and pathophysiology of lupus is now well recognized. And what you see on the right is a heat map showing expression of genes from healthy individuals. These are the columns on the left, patients with arthritis. These are the columns on the right. And in lupus patients, the columns in the middle. Now, each row represents the expression of a single gene, which are grouped together. And the alpha interferon genes are related on the top, granulopoetic genes underneath, and so on. And the red boxes indicate high expression, with the yellow and the blue lower amounts of gene expression. And what you can clearly see is that the alpha interferon related genes are highly expressed in patients with lupus. So interferon is a bridge between the innate and adaptive immune responses. It regulates the innate and is a trigger for the adaptive immune response. Interferon alpha is predominantly produced in plasmacytoid dendritic cells, which makes bucket loads of this cytokine. The sustained production is thought to be in part due to the continuous stimulation by endogenous nucleic acids, DNA, and RNA. Upregulation of interferon-related genes is shown on the right here in peripheral blood, but has also been demonstrated within organs, including skin and kidney, strongly implicating the pathogenic role of interferon in the initiation and establishment of the cytokine in lupus. So the type 1 interferon family is actually composed of 13 subtypes of interferon, but they all do bind a single receptor. So further support of the role of interferon in the pathogenesis of lupus comes from data that we know that over half of lupus patients have high levels of circulating interferon, or the interferon gene signature, IGS, which refers to the overexpression of genes regulated by interferon. First-degree relatives of patients with lupus, as well as ANA positive individuals at risk of developing SLE, have high circulating interferon alpha levels, or IGS, elevated circulating interferon, or the signature correlate with disease activity in cross-sectional studies. But interestingly, they tend to be stable longitudinally and don't fluctuate over time. However, in prospective studies, baseline levels of circulating interferon, or the signature, do associated with measures of lupus severity. So they associate with mean disease activity over time, as well as the treatments needed to control disease. So they associate with mean prednisone dose, the need to add an immunosuppression, as well as time to flare and the severity of flare. So the engagement of interferon with the interferon receptor activates JAK1 and TYK2. This then leads to the phosphorylation and activation of STAT1 and STAT2, which heterodimerize, disengage from the cytokine receptor, translocate to the nucleus, and induce expression of many, many interferon-related genes. So JAK inhibition represents a potent therapeutic approach to target interferon responses. So JAK inhibition is a potential therapeutic approach to lupus. If you think about inhibiting JAK1 or TYK2, you can block STAT1 and STAT2 activation and potentially reduce interferon-driven inflammation in lupus. And there are preclinical studies in which selective inhibition of JAK1, and these are in murine models of lupus, has shown beneficial effects on the skin and lupus in these animals. And additionally, there is downregulation of interferon-related chemokines, cell death molecules, as well as BAFF. Interferon gene signature has also been shown to be normalized in these animals that are treated with JAK1 selective inhibition. So this becomes a very promising approach to treat and to target the interferon-driven pathways in human SLE and could potentially result in decreased disease activity, a reduction in flares, as well as steroid-sparing effects. So JAK inhibition is a potential therapeutic approach for treatment in lupus. So thank you.
Thanks very much, Cynthia, for that overview. You can see a number of ways in which this pathway could be important and interesting. So now we're going to have a look at how that performs in clinical trials. Over to you, Professor Furie.
Thanks, Ed. So I'm going to provide an update on clinical trials of JAK inhibitors in lupus with a particular focus on upadacitinib. And here are my disclosures. I love this slide. This slide is an iconic slide. With this slide, you can make drugs in your basement. So basically what it shows is JAK-mediated signal transduction. And we heard from Cindy about this. But across the top, you see various cytokines, and I'll call it the y-axis on the left, the various JAKs, including JAK1, JAK2, JAK3, and TYK2. And then I have to the left of that, the drugs that I'm going to briefly discuss. So upadacitinib is a JAK1 inhibitor, whereas baricitinib is both a JAK1 and JAK2 inhibitor, and deucravacitinib is specifically an inhibitor of TYK2. So basically identify the cytokines that you want to inhibit, and then you can select the JAK that's appropriate. I'll start out with baricitinib. Baricitinib was the first drug to be studied in lupus. And we'll go back to the phase 2 study, which was a positive study, but it kind of just squeaked by. But it squeaked by enough to warrant a phase 3 program. And I'm showing you the phase 3 results. It was a typical SLE trial. There were 2 studies, BRAVE 1 and BRAVE 2. The placebo response rates in both studies were quite high. I mean, it's hard to develop a drug when you're dealing with placebo response rates that are approaching 50%. Then you can see the 2 doses of drugs studied, 2 milligrams and 4 milligrams. And out of those 4 different arms, only one arm was statistically significant. So as you probably know, this program was not pursued. Let me just briefly discuss deucravacitinib, which is a specific TYK2 inhibitor. And we heard about very nice phase 2 data. There were 3 doses and dosing regimens that were studied with deucravacitinib, and those are depicted in the shades of blue, whereas the placebo is on the far left, and that's in gray. So what we're visualizing right now is the SRI response at week 32. And actually the best response was with the lowest dose. The light blue is deucravacitinib 3 milligrams twice a day, but other doses and dosing regimens that were studied included deucravacitinib 6 milligrams twice a day and deucravacitinib just 12 milligrams once a day. And you see statistically significant differences with the lowest of the doses. In fact, the 3 milligrams twice a day dose is the dose that's being pursued in phase 3 at this time. All right, but let's turn our attention to upadacitinib, which is a JAK1 inhibitor. The phase 2 study was kind of interesting because not only was upadacitinib studied, but a novel drug, ABBV-599-HD, was studied. And the novel drug, ABBV-599, was a combination of elsobrutinib, which is a BTK inhibitor, along with upadacitinib. And there were actually 2 doses that were studied, what's called the AbbVie high dose and the AbbVie low dose. And the difference was in the high dose, it was 60 milligrams of the BTK inhibitor, but along with 30 milligrams of upadacitinib, whereas the low dose was the same 60 milligrams of elsobrutinib, the BTK inhibitor, but only 15 milligrams of upadacitinib. So the data that I'm about to show you only has 3 arms, whereas the original study included the 5 arms. So I'm going to be showing you the upadacitinib 30 milligram dose. I'm going to show you placebo. And then for the novel drug, ABBV-599, I'm just showing you the high dose, the 60 milligrams of the BTK inhibitor and the 30 milligrams of upadacitinib. Now, just a little bit word about BTK inhibitors. So we didn't fare so well in our lupus studies with BTK inhibitors, with evobrutinib and fenebrutinib. But be that as it may, this novel therapy was studied. All right, so onward to the data. All right, so as I said, we're distilling down 5 arms to 3 arms, focusing on, as you can see on the legend at the bottom, the purple is the novel combination drug, high dose. Then in the blue, upadacitinib 30 milligrams, and gray represents placebo. The primary endpoint in this SLE trial was at 24 weeks, and you see a variety of secondary endpoints. Now, the primary endpoint was the SRI-4, but in addition to that, patients had to reduce their prednisone dose to 10 milligrams or less. The secondary endpoints also at week 24 included the SRI, the BICLA, and the LL-DAS. And in each situation, you see superiority over placebo. All right, there are additional endpoints, and these were at week 48. The same outcome metrics, SRI-4, the BICLA, and the LL-DAS, and you see pretty much the same pattern. Superiority of upadacitinib over placebo in gray. And looking at flares, the overall flares were reduced, whether the patients were on upadacitinib or the combination drug. And you can divide that into mild, moderate flares or severe flares being somewhat rare, but in each situation, there seemed to be statistical significance between upadacitinib and placebo. Now, what we really want to know, because I'm not sure how much BICLAs and SRIs, and for that matter, LL-DAS really resonate with clinicians, you want to know what's happening in individual domains. So here I show you joint counts, or the so-called joint count 50, a 50% reduction in the swollen and tender joints. And the data are not real impressive at week 24, but at week 48, you do see statistical significance versus placebo. And the next is the skin response, looking at the CLASI 50, same kind of concept, a 50% reduction from the baseline CLASI activity score. But I warn you, especially if you look at the legend, the numbers are small. So in fact, rather surprising is at week 24, only 3 out of 8 patients who received upadacitinib seemed to have a CLASI 50 response, and in fact, the response rate was better with the placebo group. But again, the numbers are small. The pattern changed at week 48, and you see superiority of upadacitinib over placebo in achieving the CLASI 50. Here you see serologies, and for both upadacitinib and the combination drug, there's a reduction in DNA antibodies, and you see slight rises to a degree in the complements. But more importantly, if you look at the bottom right, you see suppression of the interferon gene signature by both upadacitinib and the combination therapy. All right, what about safety? Well, I'm not going to go through all of these items, but as far as COVID-related events, very similar between upadacitinib and placebo. Serious infections dropping down towards the bottom, a little bit higher in the upadacitinib group than in the placebo group. And what everybody wants to know about are the cardiovascular events. So there were a total of 3 events. I believe there was 1 myocardial infarction and 2 strokes, but you can see of the 3, they're evenly distributed across the groups. Now this, to my knowledge, has not been published, but it was presented, and that was a look at the biomarkers. So I just showed you that interferon pathway activity was reduced with upadacitinib. They saw an increase in absolute numbers of B cells, but a reduction in the percentage of plasmablasts and plasma cells. And they also saw a reduction in plasma levels of B cell activation proteins. Now, as far as the limitations, and basically what I showed you was the phase 2 study, and we always worry about the reproduction of our results from phase 2 to phase 3, but time will tell. But as far as limitations, steroid tapering was encouraged, but it wasn't mandatory. The sample size was a little bit on the small size, and we'd like to see a longer safety database, but that will come in time. So in summary, it was a very novel phase 2 study, originally studying 5 different treatment arms, distilled down in the results that I just showed you to 3. And we saw upadacitinib outperform placebo, achieving the primary endpoint of SRI-4 with steroid taper. And we always need reassurance because we've seen discordance between our endpoints. For example, TULIP-1, there was discordance between SRI and BICLA. So it always makes you a little bit nervous about the performance of the drug. But in this particular phase 2 study, we saw concordance for the most part between all the different metrics. So the bottom line, phase 3 is underway, and time will tell whether this drug is effective in lupus. So I thank you for listening.
Thanks very much, Rich. It's always so complicated to work through these trial data, so thanks for guiding us through that. It sounds promising, but what do we need to see in the future? For that, I'm going to hand over to Professor Christopher Edwards to talk us through the future potential.
Yeah, thanks very much, Ed. And a really interesting area to think about. And it's always interesting to think about drugs that we use for lots of other diseases and look at them in a new disease and try and work out how we fit it in. So I'm going to think a little bit about the future and what we might need to use these drugs. Here are some disclosures. Okay, so what are the challenges of treating lupus if we think about this broadly? Well, the disease is very heterogeneous. So any drug we're going to use would need to be able to treat various different aspects of disease. Often we've got comorbidities, and we've mentioned with the side effects that Richard touched on briefly that we're concerned about with JAK inhibitors, that we need to think about some of those in relation to lupus patients, cardiovascular risk, perhaps antiphospholipid syndrome, etc. We worry about treatment adherence for our patients with any disease, maybe particularly with lupus as well. And therefore, we have discussions around the benefits of oral therapies versus subcut or intravenous therapies. So let's try and summarize why JAK inhibitors might be promising for SLE. And this has been covered in the previous 2 talks to some extent. But this idea that we could target multiple cytokines simultaneously through this mechanism of action, and a number that might be of interest for lupus. So the interferons we've talked about, IL-12, 23, and other effects on different cytokines as well. And you get to have a discussion about whether it's better to block something really, really deeply, as we're doing a lot with the newer B-cell therapies, or whether it's better to perhaps have a lighter touch across a number of different cytokines. Oral administration, I mentioned, short half-life for JAK inhibitors. And there is some promise from the early trial results, although we really need the more phase 3 studies, don't we? So we can have confidence in what we're seeing. And then we have the possibility of slightly different JAK inhibitors and whether different degrees of selectivity, TYK2 versus JAK inhibition, might have beneficial effects as well. Okay, what about challenges? Well, some of this will just require the trials to run, the long-term extension studies to be seen, and then if they're successful, then clinical use will give us a better idea about the safety profile. We know a lot about JAK inhibitors already, so we can guess at what to look for, what might concern us, but it really needs longer term data. The disease heterogeneity I've talked about. Will JAKs work on all aspects? Will it be as good for joints or skin? Will it work in a kidney disease? Will it have other effects? And of course, we usually start with endpoints that concentrate more on MSK and skin, and we move to slightly scarier forms of lupus over time if things are initially successful. There are the regulatory hurdles, which start with the already the warnings on JAK inhibitors for use in other diseases. And then will it be possible to think about using JAK inhibitors in combination with some of the other therapies? Do we want to have effects on B cells as well as having effects on the pathways, the cytokines that JAK inhibitors might affect? So here are the statements from FDA and EMA around the precautions required when using JAK inhibitors for their license indications at the moment, which are largely saying do a risk assessment and be a bit careful and maybe use a different biological therapy first. Of course, this is largely for inflammatory arthritis, particularly for rheumatoid arthritis, but that's a starting point, and we're, I guess, going to need to see reassuring data within our lupus patients before we move on from those particular statements. They're going to need to be modified over time depending on what the results show. A little bit about comorbidities. If we're thinking about risks around MACE, around VTE, it's important to know that patients with lupus may have some of these problems as part of their disease activity, whether that's in the form of the effective inflammation on accelerated atherosclerosis, or whether it's on the right-hand side, the risk or VTE associated with both inflammatory disease, but more specifically with antiphospholipid syndrome. And it's also worth reflecting the sort of patients we treat. I mean, one of the interesting things about having trials of JAK inhibitors of lots of disease areas is we get to look in different populations. So we know the spectrum of the patients who have lupus. They tend to be slightly younger in the trials than the patients that have rheumatoid arthritis. And now we have trials of JAK inhibitors, of upadacitinib, in giant cell arteritis, an older population. And so you get to see this spread of risk across different diseases, but also different age groups as well. And of course, often women with lupus are in an age when they have reproductive potential. And of course, we would need to be cautious about JAK inhibitors in that context. Although one benefit of JAK inhibitors is that the half-life is short. So if you decided you wanted to conceive, you can stop and it's out of the system pretty quickly. The disease also varies over time. So any new therapy needs to be able to control the initial phase of disease, have an effect of on flares. Some of that data has been collected in the trials. And then we want to be able to use this on the long term over time. And that's important for control of the disease, but the longer we're using drugs, the more important our understanding of the long-term safety profile is as well. Now, I thought I would go to clinicaltrials.gov and have a look at the current studies that are underway. Some of us are involved in some of the recruiting to some of these studies, but just to look what other data will become available as we think about what we'd like to know. So Select SLE phase 3 for upadacitinib. That will have a 104-week extension. That will give us efficacy and some more long-term adverse event data as well. And then for deucravacitinib and the Poetic 1 and 2 studies, that'll have long-term extension data out to 156 weeks. And once again, will give us longer-term efficacy and safety data. So some of this data is coming and on its way. But there are other things we'd probably like to know, and this will depend on successful phase 3 studies, people starting to look at the long-term extension. And then if it gets to the point of use in the clinic, we'll be able to generate information from registries, real-world evidence, which all adds to the information that we have. So we want to know more about how long the effect lasts, whether it wears off over time, long-term safety I've mentioned a few times. Does it prevent damage to organs? Does it reduce steroid use? And then other effects around effects on comorbidities, quality of life, all the sorts of things that we want to collect when we want to understand more fully drugs with a particular mechanism of action. And ultimately, you might put them head to head against existing therapies as well, if someone has the courage to do those studies. Okay, last few slides are just about thinking about where JAK inhibitors might fit in. Here's EULAR recommendations. Ed Vital showed some of the new BSR recommendations as well at the recent BSR meeting. So there are various recommendations available. But there are a number of different therapies we use, from the use of corticosteroids that we're trying to reduce as much as we can through hydroxychloroquine, immunosuppressants, and then a concentration on B-cell depletion through some of the new therapies, belimumab, and interferon effects, anifrolumab. And there are others, of course, you'll know about that are in development. And this is a slide from Laurent Arnaud looking at the development program for other therapies. And if you look on the top towards the end of 2027, you can see when the reporting of the deucravacitinib trials are expected. If you look just underneath that, you can see the select SLE for upadacitinib. So we're looking at having that phase 3 data in the next couple of years. So we still have a little bit of time to think about these therapies. So finally, thinking about JAK inhibitors and summing up. So what do we know so far? Well, we've had a very nice introduction to the way JAKs work. And then we've thought about some of the trial data. For me, it's interesting that we've got extensive experience in other disease areas. These drugs are often licensed in other diseases, and that gives us experience and sometimes the chance to have used them in people who have lupus overlap type syndrome sometimes as well. So sometimes we've collected a little bit of clinical experience before the phase 3 studies. Short half-life, and then although we know the risk factors that have been highlighted for JAK inhibitors, we want to know if those might be different in the context of the typical lupus patient, and there'll always be that concern around VT and antiphospholipid syndrome. Okay, so that's me done. Thank you very much.
Thanks, Chris. So 3 great presentations there. I was thinking as we were going through of sort of, well, not just questions, but also reflections, I guess, on several of them. And one of the first things I thought was like Cindy, what you showed, like, where people are used to JAK inhibitors already, because we already prescribe them for other patients, but the reasons why we might use them in lupus are really quite different potentially from what they are in rheumatoid arthritis or psoriatic arthritis or something like that, isn't it? Right.
No, that's true. And the JAK inhibitors, as Christopher pointed out, have the advantage of being an oral agent, and much easier for patients to take and to tolerate.
Yeah, and also it's like here, for example, as you explained, it's a type 1 interferon therapy, which we really like for lupus, but that's so much more important for lupus than it would be maybe in some of the other diseases where we've used JAK inhibitors in the past. So even though we feel like we know them, there kind of might be a kind of somewhat different treatment in this disease from what we know. And I guess that differentiation from, we've already got a type 1 inhibitor for lupus with anifrolumab, and we know that works, but there's a differentiation there as well, isn't there? Because you're blocking all these other cytokines. So it's quite intriguing, I think, really. And then
let me ask you a question, Ed.
Yeah.
So the role of gamma interferon, which is going to be inhibited by JAK1, what's your view on that in lupus?
Now so we had this really interesting conversation at a meeting, well, at the Toronto meeting that we were at last week about this, because we were having a discussion about biomarkers, and people think there are different interferon signatures for type 1 and type 2 interferons that might associate with different, and type 2 being gamma, that is, that might associate with different features. And I was talking, Peggy Crow was there, lots of other people working on interferon, and none of us felt that we completely understood what those signatures tell us. So, but saying that there is a slightly different interferon signature that has been attributed to gamma interferon and seems to show better correlation to lots of outcomes like onset of lupus or flares and things like that. And it makes sense, I think, doesn't it? That's also important for lupus pathology.
Yeah, that's an important point, is that there's no one strict definition of what the interferon gene signature is. And, as it's been looked at in multiple translational studies, the question is, how do you define it? And it's been defined differently. I'm not going to say in every study, but it's defined very differently among different groups of researchers.
Yeah. I mean, but the other thing I think is interesting with JAK inhibitors is most of the treatments we've used to in the past with lupus are basically working on white blood cells, like mycophenolate and cyclophosphamide or belimumab and rituximab and things like that. But as we just heard, the effect, these molecules, these cytokines and interferons are not just limited to what's in the circulation. There's all these things in target organs, aren't there? Tubular epithelial cells, resident macrophages, all of these things that play a role in lupus that might be affected by these treatments. So it's fascinating, really. Which actually led me to another question for Rich, which is that, like you said, when we look at a trial, we're used to the fact that you have to look across all the endpoints and make your own mind up about what it's doing. We can't just rely on a p-value to tell us what benefit of each drug. We're going to have to take a broader view of it. Also, the data you showed about BTK, TYK2, JAK1 and 2 looked different. Do you think are those real differences, or do you think they're just a bugs in trials that make it look like there are differences?
Wait, you mean the difference between deucravacitinib and upadacitinib?
Yeah, to these drugs, do you think they're really having, visibly different effects on patients, or are these just quirks of the way trial outcomes come out?
I guess my view of it is that the results were more similar than dissimilar. Did you think different?
We saw in some of the trials you saw better. So some trials you saw better results for skin than joints, sometimes more the other way around, right?
Oh, but for these two, well, I think any drug that inhibits type 1 interferon is going to work in skin.
Yeah.
So we saw that with deucravacitinib. I don't know that it's ever been published, but Michelle Kallenberg presented at the ACR meeting in Philadelphia the effect of deucravacitinib on the interferon gene signature. And as I recall, there was about a 50% inhibition of the gene signature. Anyway, the bottom line is any drug that inhibits type 1 interferons is going to work in skin. Now, joints, we have a problem, and you're going to solve that problem for us. So first of all, I mean, the pathophysiology is probably different than with skin. But more importantly, our ability to measure reproducibly lupus arthritis, I worry about.
Yeah,
that was the downfall of TULIP-1. So when arthritis doesn't work for a drug, you don't know if it's the drug itself or if it's the measurement of arthritis. Yeah, so in the UPA study, there were a fair amount of patients with arthritis. For skin, there weren't a whole lot with very active skin.
Yeah.
I was just going to add in, that's where the importance of measures like ultrasound examination of joints becomes increasingly important, as Ed has spent lots of time working. We had a joint project that you led a while ago, Ed, didn't we? Looking at that and trying to understand it and to exclude those individuals who just had pain in the joint rather than inflammation in the joint, which is important for it.
And the other thing that we're talking about is that there's this project called TRM SLE, which lots of us are members of, that is trying to come up with better endpoints for trials. And we've looked at arthritis or musculoskeletal features in a couple of ways. So one is you can use those ultrasound data to try and make a better clinical index. So you don't have to use a scan every time. You can make up a kind of DAS28 for lupus arthritis with things like physician VAS, patient VAS in their joint counts that's more continuous, that hopefully would work better. And then the other thing that Ken Kalunian's done alongside that, we're trying to bring these things together, is that actually which joints you assess might be quite important. You know, like, is really looking for swelling in the shoulders a good way to assess lupus? They're always tender, even if you haven't got an inflammatory arthritis. So you know, like, actually, if you refine the joint count set, you might improve things as well. So we're trying to make that a bit better assessment. And then one of my other thoughts, actually, that I thought in your talk, Chris, was like, one thing you made me think about is that when we talk about what do we need in lupus therapies, like to do better, like the most obvious thing is you look at the trials and hope for bigger deltas between the two treatment groups, but that might not really be what we need, isn't it? It might be more like using the drugs in different ways, earlier, treat to target, whatever, you know, different ways of using therapies rather than just more.
Yeah, and there might also be different benefits. The speed of onset might be different. The short half-life, and it can get out of the system in a patient that has a risk of infection. So there are things about the design of the pharmacology of the drug itself, the pharmacokinetics, the pharmacodynamics of the drug. And then whether conceptually, and people have had these discussions around inflammatory arthritis as well, you know, that whether there really is a difference in simultaneously having an effect on multiple cytokines and cell types, whether that really makes a difference, whether that's better or different than very deeply taking out one cytokine or one cell type. And you're right, it could be used in different ways. We're more comfortable using it in combinations with other therapies in other disease areas. So with other immunosuppressants, we already know how we use that. And then, of course, you know, when we talk about these things, we think about trials where people have lupus or they have rheumatoid. And in the real world, lots of people have something that's probably.
Yeah.
And so knowing that drugs can work in multiple disease areas can be really useful.
These trials that look for response, that's how we identify the medicines that might be useful. But what we're really going to achieve might involve a bit more than that, actually.
Yeah, absolutely right. Those are the licensing studies, aren't they? And they're vital, but they don't tell us how we're going to use them always.
And then you work out the unique properties of this agent, like JAK inhibitors, like we said, like oral, does things in different tissues, complementary maybe to B-cell blocking therapies and things, and work out its role, which is an interesting set of questions coming up in the future, I think.
Absolutely right.
So I think that's all we've got time for today. So thank you to all our speakers for those discussions. And thank you to AbbVie for supporting this program with an unrestricted grant. AbbVie didn't influence the content of these presentations. And this is going to be on Lupus Forum for you to review and look at our slides in future. So if you have a look, sign up to lupusforum.com and you can get updates when we release new content. Thanks very much.